tonight is part 2 of the eosinophilic gastrointestinal diseases, EGIDs, the whole cut. I'm very, very excited to be covering this. We were talking just briefly before you come on. I think this is quite revolutionary. We're moving forward into a phase of not separating the gut up into separate sections and thinking about you as a whole person. And so that's what we'll be doing this evening. And just to introduce you to the team, I'm very lucky. We have a driving force for impact, trying to make a change for your lives. And for those of you that don't know me, I'm the CEO and founder. My name is Amanda Cordell. I'm not only the founder, but I'm also a parent of 2 children who were diagnosed with eosinophilic disease very early in life. They are now 18 and 22, which makes me feel old. And alongside me is my colleague, Alina. She will be working in the background to ensure that you're all supported during the call. If you have any issues, you may have already been in touch with her already in getting your registration sorted. So don't worry, there's somebody there to help you. And Karen gives her apologies because she's actually on holiday, although I say that shortly because she's looking after her grandchildren. So I'm not sure whether that's a holiday or not, but she wishes she could be here with you. Okay, so what are we going to cover tonight? First session was covering diagnosis, the symptoms, looking at how common it is, and now we're moving on to thinking about what treatment options there are, also the holistic picture of how you can improve your quality of life, and looking at the long-term management and follow-up care, because we know these are chronic diseases, and then looking finally to the future. What does that look like in diagnosis, treatment and care development? So I think that's probably the most exciting topic out of them all. So further ado, I'm going to introduce 2 wonderful people that I've had the pleasure of working alongside with Segear, and they're both from the United States. They're both dedicated to eosinophilic diseases. Our first speaker will be Nirmala Gonsalves, and she is from the Northwestern Medicine Feinberg School and is a professor of medicine in gastroenterology and hepatology. And then secondly, we will be welcoming Catherine Peterson, who is also a professor of gastroenterology in the University of Utah. And so at that point, I'm going to hand you over. I'm going to stop sharing my screen.
Okay, well, good evening, everyone. Thank you to Amanda and the EOS Network for the invitation to join you all today on this journey of learning about eosinophilic GI diseases, part 2. The topic that I was given, so I'm going to take the first half and Dr. Peterson will take the second half. I'll be reviewing with you treatment options, specifically medication, diets, and even esophageal dilation. And then we'll talk about how those are very important, particularly in improving and affecting the quality of life in the EGIDs. So when we think about, and you probably saw this from Dr. Dellon and Salvatore's talk, but when we think about eosinophilic GI disease, we think about this as a whole category of disorders. The whole entire category is eosinophilic GI disease. When it's limited to the esophagus, this is eosinophilic esophagitis. And that's what I'm going to start with. The second half of the talk will focus on other locations, non-EoE EGIDs. So when we think about treating eosinophilic GI disorders, we really think about a treat to target process. And what does that actually mean? It means as clinicians, we want to make sure our treatment is improving symptoms. So for EoE specifically, resolving dysphagia without the need to adjust foods or textures, improving that inflammation or histopathology, so making sure those biopsy specimens have a reduction, ideally under 15 in those eosinophils, and improvement in endoscopic features, so making sure those changes in the esophagus that patients have get better, both from the inflammation and stricture standpoint. Now, why is that even important? It's important because we know from numerous studies that EoE and eosinophilic GI disorders have a significant impact on quality of life. This is a recent study by Dr. Schiffer and colleagues that looked and polled patients, all patients, adolescent patients as well as adult patients, and really asked them about issues and how EoE and EGID affected them. And I think this is a very telling slide. in terms of how many patients are really affected and the themes of what are infected. So they talk about being bothered by symptoms of EoE, being worried about trouble swallowing, choking, feeling embarrassed, worried about having trouble swallowing in public settings, taking part in social activities, their relationships with families and friends, keeping up with school or work, having to miss work or school, and having sleep disruption. So this is quite profound and definitely important as we think about treatment options and why treating EoE is important. So when we think about treatment options in EoE, it typically focuses around medications, diet, esophageal dilation. We'll talk about medical therapy, including PPIs, swallow topical corticosteroids, and biologic therapy. We'll highlight dietary therapy and even talk about endoscopic therapy. And the way I thought I would organize this talk is to highlight it with the common questions that patients ask me in clinic and how to answer them and what the evidence is behind this. So the first question they would ask is, why are you treating me with an acid reducer, that PPI, if I have EoE and I don't have reflux? And I think that's a really good question. And I think this is information that helps patients understand why a PPI can be an important therapy. So this is data from the AGA's guidelines several years ago, and they reviewed many studies looking at PPIs and their response. So the percent achieving histologic response, meaning getting rid of all those eosinophils, was 42%, so really quite good with the PPI. Furthermore, studies from Europe show that PPIs reduce symptoms and endoscopic features of EoE in children and adults. This is a large study, 630 patients. And what you can see here on the left panel, that 71% had improvement in symptoms and 48% had improvement in that histologic inflammation, the eosinophils, after treatment with a PPI, a proton pump inhibitor. Now, this study went on to show that these medications improve fibrostenotic features of EoE. So we know that patients with EoE can have a lot of strictures and narrow esophagus. And what you can see here on the left panel is that there is an improvement in those endoscopic reference scores, meaning the features of EoE, strictures, the inflammatory features. So compared to swallow topical corticosteroids, the PPIs did improve these. And on the right panel, you can see that the PPIs even increased that luminal diameter, meaning helped expand that esophagus after treatment. And that was quite surprising. We didn't think they would even do that. So practical considerations when we talk about the use of PPI therapy in EoE, they're no longer required for the diagnosis of EoE. It's actually a treatment. And they're a popular first-line treatment, secondary to widespread availability, the ease of administration, and safety of the medications. The loss of that therapeutic benefit with prolonged use is reported but uncommon. So typically once it works, it tends to continue to work. Our typical starting doses in the US are omeprazole 40 milligrams once a day or 20 milligrams twice a day or the equivalent of that. Next question is, how effective are topical corticosteroids and what are the side effects? So here's data again from the AGA guidelines showing that the swallowed topical corticosteroids show that the percent achieving histologic response, again, getting rid of those eosinophils, is 65%, so really quite good. This is a study looking at budesonide oral suspension and showing improvement in outcomes in EoE. This was a study done in the US with patients 11 to 55 years of age. They received either this budesonide oral suspension, 2 milligrams twice a day, or placebo for 12 weeks, and they had a significant improvement in the inflammation, the histology here compared to placebo, and an improvement in their dysphagia symptom score, meaning they felt better. And this led to the FDA approving this budesonide oral suspension to treat EoE in children over the ages of 11 years. So practical approaches to swallow topical corticosteroid in EoE. Current treatment is typically given for 8 to 12 weeks. There are various different formulations out there, and this is specific to the US, but there are additional formulations with the budesonide oral dispersible tablet in Australia. But these are the formulations out there. For the US, the budesonide oral suspension is the only one that's FDA approved. Here are the dose ranges, and we typically use lower doses in pediatrics. Adverse effects such as candidiasis, thrush, or adrenal insufficiency. Candidiasis and thrush are a fungal infection in your mouth or your esophagus, usually asymptomatic, meaning you don't have symptoms. All of these things are quite uncommon. Next, patients will say, well, I hear this is a food allergy, and eliminating foods helps the disease, but how effective is this, and how does it work? That's a really great question. So when we think about effectiveness, I mean, the first thing that was looked at and reviewed was an elemental diet. An elemental diet is a purely amino acid-based formula diet. And you can see here, percent achieving response is 94%. Really good, the most effective diet therapy, but elemental diet is very challenging, both from a cost, palatability standpoint, also reintroducing foods when you're starting from the basic building blocks of amino acids can be quite challenging. So it's really not favored. Next, patients will ask about allergy testing directed diets. And over here, you can see the data that all the studies are sort of all over the map. So even though the percent achieving histologic response is 50% here, this assessment was rated down because the studies were all over the map, and therefore allergy testing directed diets are no longer advised in EoE. There's a very poor correlation with skin testing, patch testing, and what patients' food triggers actually are. So the favored diet approach is really a 6-food elimination, an empiric elimination diet. At the time of the guidelines, they used data with a 6-food elimination diet. And you can see here, and that's eliminating milk, wheat, soy, egg, nuts, and seafood. The percent achieving histologic response was 68%. So really quite good and comparable to what was seen in the topical corticosteroids. Now, since those initial guidelines, there's been a lot of comparisons of diet therapy for EoE in children and adults. Here you can see the elemental diet up at the top, 6-food elimination diet, 4-food, which is milk, wheat, soy, and egg, 2-food, milk and wheat, allergy testing down here in a single food. You can see here as you eliminate fewer and fewer things, that effectiveness does tend to decrease, but it just highlights that there are multiple options that are available. There have been 2 randomized diet studies in EoE, and by that, I mean that patients were given one of 2 options. They were randomized to these options. And here you can see in pediatrics, it was a milk versus a 4-food, in adults, milk versus 6-food. And the results were really quite comparable, which was a little bit surprising. We thought that the more extensive elimination diet would be much more superior than a single food, and this did not turn out to be the case. Interestingly, 45% of patients in this SOFI group, this is the adult study, this is a pediatric study, 45% of patients who failed to respond to this milk only ultimately responded to the 6-food elimination diet. So if someone doesn't respond to that single food, it doesn't mean that they cannot respond to a more extensive diet therapy. What about practicalities? Those were clinical trials. What about real-world experience? Our group at Northwestern looked at our experience with patients who did that empiric elimination diet. We found that 54% had a full histologic response after 6-food. If they didn't respond initially and wanted to try it again, that number went up to 58%. But the most important thing that came out of the study was this number here, that 69% had only one food trigger identified. So that's really helpful, at least in the US. This was a US study, to tell patients that the likelihood is if you go through diet therapy, we would most likely find only one food trigger, and that might be slightly different than other parts of the world. Now, everything I've talked to you about in terms of this diet is a step down approach, meaning taking everything out and then adding it back in. What about a step up approach? Starting simple and then building. And this is what we see here. This is data from the Spanish group. If they take out just 2 food groups, it's 44% effective. For patients who didn't respond, they took out the 2 foods and the 4 foods. So, 2 additional foods. So they took out really 4 foods. That's 60%. For those that didn't respond to the 4 foods, they went on the traditional 6-food diet and resulted in an 80% response. So again, you can come at it this way, starting simple and then building if patients did not respond. So bottom line, there are multiple options for diet therapy that are available. Important to discuss the right strategy with patients based on their goals of care and come up to a shared decision there. So practical approach, diet therapies are effective first-line options for children and adults. Empirical elimination diets are the preferred approach. There are multiple empirical elimination diets that are available. There's no one best approach. Consultation with a dietitian is really important for patient education. Food reintroduction is essential to identify specific food triggers, so we don't just take things out of the diet and then leave patients off of them. We do the food reintroduction process. And the timing of diet initiation is critical for success. And what I mean by that is that if you have a patient or you are a patient and you know that you're going to have a really busy time at work, you're traveling a lot for work or school, going off to college, that might not be the right time to start diet. You might want to wait until life is a little bit more predictable to get that success. Next, I feel great after my therapy and dilation. Do I really need to stay on therapy? Such an excellent question. And this is the answer and how we answer for patients. We really talk about long-term inflammation leading to fibrous stenosis. And this has been seen in multiple studies. I'll highlight just two. One from Switzerland that showed that the prevalence of fibrotic features, so stricturing, increased from 47% with a diagnostic delay of 2 years to up to 80% with a diagnostic delay of 20 years. And then Dr. Dellon and colleagues showed that every 10-year increase in age, the odds of this fibrostenotic phenotype more than doubles. So it suggests if we don't continue to treat, there's a higher risk of these strictures. And the AGA did give some guidance on this. And at that time, there was only maintenance data with topical corticosteroids saying that in patients with remission, they should maintain on this therapy. We've seen this in the budesonide oral dispersible tablet studies, and this was the maintenance arm of that study. Patients were randomized to that budesonide oral dispersible tablet at high dose, low dose, or placebo, and their primary endpoint was the proportion of patients in remission. And what you can see here is that patients on therapy were much more likely to be in remission compared to those on placebo. They also found that the median time to clinical relapse, meaning when symptoms come back, was over 350 days in the treatment arm compared to only 87 days in the placebo. And another really good study showed that patients who stayed on their therapy, their swallowed topical corticosteroids, were much less likely to get food impactions than those that stopped their therapy. So bottom line, maintenance therapy, staying on your medications. EoE is a chronic disease. Symptoms and esophageal eosinophilia persist without treatment. Both medical and dietary therapy can be effective maintenance treatments. And we always want to consider dose reduction in that swallowed topical dose when we're using it for long term. And with diet therapy, pursuing food reintroduction to liberalize those diet and identify triggers. There is near universal recurrence if treatment is stopped, which is why we advocate for maintenance therapy. Next, I'm nervous about the esophageal dilation. Is it safe to do, and how do you dilate the esophagus? So here's the data with the esophageal dilation showing that the percent achieving symptomatic improvement is 87%. So that makes sense. If there's a narrowing and a speed bump in your esophagus, if we open that up, that's going to help the esophagus swallow more smoothly. What's important is that there's really decade or so ago, everyone was very concerned about doing esophageal dilation, the risk. However, there's been no mortality associated with dilation, and the pooled complication rate is really quite low. Perforation rate being 0.4%, hospitalization 1.2%. The biggest thing that we tell our patients is that you can have some chest discomfort or pain as high as 74% after a dilation. So typically, my own practice is putting people on a liquid diet the day of the dilation to just help with that. It's important to go through those side effects and these complication risks ahead of time before thinking about a dilation. Practical approach to dilation, medical and dietary therapy can improve that stricture caliber, can usually open it up a couple of millimeters with each, but may not resolve it completely. Dilation does not affect that underlying inflammation, so use it as adjunctive therapy. Conservative dilation approach is imperative. So what we tell our trainees is start low and go slow to a target endpoint of 16 millimeters, meaning that if someone starts off with a really small esophagus, it's going to take several times, several dilations and a series of dilations to help open up that esophagus. The type of dilator that we use is really determined by the type of stricture, and we can talk more about that in the discussion. There have been many societies now that also advocate that endoscopic dilation should be considered for all EoE patients with dysphagia. What causes EoE, and are there any new therapies? Well, this could be a talk in and of itself. I'll try to go through this quickly. So basically, this is what it looks like in terms of what's happening beneath the surface. There's lots of food and air allergens that traffic across that esophagus that results in setting off lots of signals such as IL-33, TSLP, which stimulate inflammatory cells to set off even more signals, with the endpoint of all these eosinophils and mast cells going to that esophagus, creating eosinophilic inflammation and remodeling of that esophagus. I'm going to focus here on these agents here, IL-4, IL-13, and IL-5, because they've been studied most extensively. Anti-IL-5 therapy in EoE, mepolizumab, bresilizumab, benralizumab has all been looked at in EoE. The studies have a common theme. They've shown significant reduction in tissue eosinophils, but unfortunately no significant reduction in symptoms. So this may not be the right target. What about anti-IL-13 alone? This was a study looking at, with cendakimab, looking at randomized double-blind placebo-controlled phase 2 clinical trial in patients ages 18 to 65 who got a low dose, high dose, or placebo, and their primary endpoint was the mean esophageal eosinophil count. And here's their data. You can see significant reduction in the phase 2 study in the low dose, high dose, improvement in the esophagus based on the EREFs or endoscopic changes. A phase 3 trial was completed with an ACG abstract showing similar improvements in their primary endpoint. However, the future of this agent is still unclear. Dupilumab, this is an IL-4 receptor alpha monoclonal antibody. It targets both IL-4 and IL-13, and it's been approved for multiple atopic conditions. I will highlight the phase 3 part A data in EoE with co-primary endpoints, meaning improvement in histology, those eosinophils in 60%, improvement in dysphagia symptom scores as well was quite significant. And this led to the approval of this agent for adult and pediatric patients over 12 years. And in January 2024, approval for children over the age of 1. So many questions come up in terms of how to use this, where to position this. First line, and this is guidance from a multidisciplinary group in the Annals of Allergy and Asthma Immunology, suggesting first-line therapy could be in patients with multiple comorbid conditions, such as the persistent asthma, dermatitis, nasal polyposis, or patients with a strong preference to avoid diet restriction or swallow topical corticosteroids. EoE that's difficult, so second line here is EoE that's difficult to treat. They're having frequent use of rescue therapy, severe diet restriction, or requiring amino acid formula significantly, having esophageal strictures or narrow caliber esophagus, or they're refractory to current therapy. So this could also be a second line therapy for this agent. So piecing the treatment part all together, if you have a patient with EoE, they can be started on a PPI for 8 weeks, or empiric elimination diet for 6 weeks, or swallow topical corticosteroids for 8 to 12 weeks, the budesonide oral suspension here being FDA approved, or dupilumab for 4 to 6 months. We would repeat that endoscopy with esophageal biopsy. If they're in symptomatic and histologic remission, meaning symptoms go away, the eosinophils go away, then you would put them on maintenance therapy. Either leave them on the PPI if they're on there. If you do diet therapy, start reintroducing foods. If you're on the topical corticosteroids, stay on maintenance therapy, and of course, maintenance dupilumab. If they have persistent symptoms or lots of inflammation, then think about adherence to the medication. If they weren't started on PPI initially, add that for uncontrolled reflux. Think about further elimination diet if you started with just one food. Thinking about changing formulation of your swallow topical corticosteroids, thinking about a biologic therapy or dupilumab, and certainly esophageal dilation if you have scar tissue there that's contributing. And after you make these changes, repeating that endoscopy with biopsy to make sure it's working. Next, I'm going to move on in the last time I have. And Kathy, I know you said your talk is a little bit shorter, so I'm going to steal about 5 minutes of your time here. So essentially, the second part is this non-EoE EGID. So if inflammation is located anywhere else in the stomach, eosinophilic gastritis, small bowel, eosinophilic enteritis, colon, eosinophilic colitis, we refer to this all as non-EoE EGID. So this part will now, in addition to classifying it by organ, it can also be classified by layer. So EGIDs can be mucosal, the inner layer of this donut, muscular, the meat of the donut, and serosa, the outside of the donut, if you think about your gut as a donut. Now, again, similar to EoE, we would want to think about treat to target in EGID. And this is a little bit more amorphous because we don't have clear endpoints here. These diseases are much more rare, but we want improvement in symptoms. We want improvement in that eosinophil, and we want improvement in those endoscopic changes that you see in non-EoE. Now, why is treatment important? Well, even here, there's a significant impact on health-related quality of life. This is a study that we did at Northwestern looking at patients with EOG or EON who completed questionnaires, and we found significant impact on psychosocial impact of diagnosis, impact on social relationships, financial impact, and impact on the body. Another study from North Carolina looking at a cross-sectional study and a contact registry showed that non-EoE EGID patients had more frequent and non-specific symptoms of nausea, pain, diarrhea, constipation, bloating, and a higher frequency of fatigue and isolation. Our group at Northwestern recently published on our initial validation of an eosinophilic gastritis and enteritis quality of life scale. So this is the first disease-specific measure of this. And we found that the scores really did correlate with symptom severity, symptom frequency, duration, anxiety, depression, fatigue, and sleep disturbance. And these are non-EoE EGIDs. And that the scores also correlated with a number of outpatient allergy visits as well as total outpatient visits. Again, when we think about disease burden, patients with non-EoE EGID have a significant diagnostic delay, anywhere from 5 to 8 years, because there's a lot of things that factor into this. Patients have amorphous symptoms. Patients may have amorphous symptoms, and so they may never get referred to a gastroenterologist. At that time, they may never have endoscopy with biopsy. Biopsies may be taken, but they may not have the appropriate histologic assessment at this time. So you really need all of these steps along the way, which you probably heard about in part 1 of this series, in order to make the diagnosis. But making the diagnosis is very important so that we can start treatment. Now, treatment here is even more troubling or challenging than with EoE because there really aren't any FDA-approved therapies. There's a lack of large studies or in clinical data. Current approaches focus around steroids, PPIs, the mast cell stabilizers, diet, immunomodulators, and biologic therapies in the form of clinical trials. Steroids have been the mainstay. Prednisone, oral prednisone, 20 to 40 milligrams a day can induce remission, but we know that prednisone can have some pretty harsh side effects, so we really want to taper patients off of them quickly, and that's when enteric-coated budesonide has come up. That is opening up these budesonide capsules, crushing the medicine, and taking that with a spoon of honey or applesauce and taking it on an empty stomach. That's akin to that swallow topical budesonide for the esophagus. We're trying to do that for the stomach. PPIs have been shown in EoE to be helpful. 61% of patients in a large SEEKR study were tried on PPIs in a large multi-center study. So we know that patients with eosinophilic gastritis, enteritis can have erosions, ulcerations, so PPIs can be a good therapy. Cromolyn sodium, it's a mast cell stabilizer. It stabilizes these other inflammatory cells. It's used 800 milligrams per day divided in 4 equal doses. It's an adjunctive therapy. It's not a primary therapy, but it can be helpful, particularly in some patients for pain. Immunomodulators, these are medications called azathioprine, tacrolimus, methotrexate. They're used similarly to inflammatory bowel disease as steroid-sparing agents, meaning helping patients get off prednisone. Again, similar to what we know about in EoE, non-EoE EGID has a similar pathophysiology, and we'll focus a little bit here on these signals, IL-4, IL-13, and IL-5. So biologic therapy in non-EoE EGIDs, anti-IL-5 therapy or benralizumab has been looked at in an hypereosinophilic population, as well as a phase 2 trial of eosinophilic gastritis, similar to what was seen in EoE, reduced eosinophils, but there was persistence of endoscopic and histologic features. There's been some case reports using a medication called vedolizumab, which is used in inflammatory bowel disease, in small case reports showing improvement in small intestinal and colon eosinophils. Anticyclic 8 or lirentelimab in a phase 2 trial showed very impressive reduction in histology and symptoms. However, the phase 3 study, while it showed improvement in the histology, it did not show that significant signal in the symptoms. Anti-IL-4 dupilumab has also been looked at in the DAGOS study. This is a phase 2 study, and I'll show you the data that was presented in DDW, and an ongoing study called ENGAGE, like gastritis with or without duodenitis. So the DAGOS study here was a placebo-controlled trial. Patients got medication versus placebo and then went on to an open label extension. The most important data here to show you is that there was a significant reduction in the change in gastric eosinophil count in the treatment group compared to placebo. There's also improvement in the absolute change in eosinophil count compared to placebo. Improvement in the EOG-HSS score, that's a histology grading score, similar to the grading score in the esophagus. And an improvement in the EG-REFS, which is similar to the E-REF. So this is an endoscopic score, so some improvement in the treatment arm. Dietary therapy is even less known about. This was our element study in collaboration with Seeger, showing impressive. This was an adult study, ages 18 to 65. Patients were just given elemental diet for 6 weeks, and you can see an impressive reduction in eosinophils in both the stomach and the duodenum. 100% of patients met that primary endpoint of complete remission. And they also had significant improvement in symptoms, endoscopic features, and molecular profile. So how do we piece this together? We really say treatment options are based on the severity of the disease. So if someone has mild disease here, mild endoscopic features, maybe a trial of a PPI, maybe a trial of a topical crushed corticosteroid or empiric elimination. Once they start getting more moderate disease, starting to think about a little combination therapy, PPI with the crushed budesonide, PPI with empiric diet. Once they're really severe, that's when they need systemic therapy, PPI with oral steroids or PPI with elemental diet, thinking about biologic therapy, surgical consultation if they have non-healing ulcers or strictures, and certainly if there's really high eosinophils, referring to a hematologist, so to rule out something called hypereosinophilic syndrome. So piecing it all together here in a patient with eosinophilic gastritis or duodenitis, similar to EoE algorithm, you can start with a PPI for 8 weeks, dietary therapy, oral or topical corticosteroids. Again, we don't have anything FDA approved in the US or other. Afterwards, repeat an endoscopy with biopsy. If patients are in remission, the highlight here is maintenance therapy. If they have persistent inflammation or symptoms similar to the EoE algorithm, start thinking about adherence, adding PPIs if you didn't, thinking about further elimination or elemental diet, thinking about going to prednisone if you started a topical corticosteroid, and if you have clinical trials and access to that, thinking about biologic therapy, and after these interventions, repeating that endoscopy. And so I have walked you through the treatments of both EoE and non-EoE EGIDs and highlighted, hopefully, the importance of why treatment is important and how it can affect quality of life. And with that, I will pass the baton to Dr. Peterson and stop sharing my screen. Thank you.
Well, for everybody out there, I'm Kathy Peterson, and I'm an adult gastroenterologist at the University of Utah. And I have been inspired by NIMI and colleagues to try to solve problems with eosinophilic gastrointestinal disease, whether I can actually do that or not. But and so I'm going to talk to you guys today. I was going to follow up. Let me see if I can get my little slideshow going. There we go. All right. Hopefully everybody can see that. So I'm just going to talk a little bit about the chronicity and the transition of eosinophilic disease. Nimi did a fantastic job. So I don't have as many slides on eosinophilic esophagitis, but I will include that because that is something that goes along with other lower eosinophilic diseases. And I think it's like really hard to fit all of this in a half an hour. I'm so sorry about that, but I will do the best that I can. So Nimi's kind of covered a lot of this, but what we do know is that these eosinophilic disorders are increasing. So the incidence is increasing, and because it's a chronic disease, then we know that the prevalence is increasing even more. And so ultimately, this is going to become a huge healthcare burden, if it already is, but it's going to even become more of one because we have this chronic disease that we keep on diagnosing more and more patients. And so we think we have increased awareness, but also increased cases. And eosinophilic gastroenteritis is very similar to eosinophilic esophagitis, that we think it is also increasing in incidence. Sweden did a publication where they show a slow increase in detection over time. We're now seeing that it's getting identified more and more, and probably we'll actually see a sharp spike in it when we can actually really define distinct criteria how people need to diagnose it, and we get everybody on board. It takes a little bit of inertia and a little bit of time getting everybody on board to actually kind of surround and like agree that these criteria need to be met. Part of the issue that we deal with too is that these diseases often present, also depending on the age, with very kind of non-specific symptoms. And so EoE, we've gotten very lucky in adults, you know, people tend to choke for the most part or tend to have dysphagia and trouble swallowing. But in kids, it's not the same. And eosinophilic gastroenteritis and colitis are even harder to identify. So we think that we're a little bit behind the 8 ball in our medical fields, like actually identifying disease when we need to. And as Nimi mentioned, you know, the diagnosis actually is delayed commonly, and it's probably a combination of non-specific symptoms, a lack of awareness in the disease, a lack of actually awareness of how to do the biopsies and when to do an endoscopy, and if it is abnormal or not, or it doesn't matter if it's abnormal or not abnormal. And then again, on the pathologist side, a lack of that awareness to actually look and enumerate eosinophils in the tissues. So we have a lot of work ahead of us to try to figure out how to make this a very streamlined approach. And then hopefully over time, we'll be able to improve our diagnostic delay. As I mentioned earlier, clinical diagnosis, the clinical presentation makes a diagnosis even of EoE difficult, right? So when children are young, they don't always complain of trouble swallowing. They have other symptoms. They have feeding difficulties or refusal, or they fall off the weight chart. And then as they get older, or as people get older, more and more of the symptoms at EoE will isolate to the esophagus. But we always have to remember that these diseases can overlap, as Nimi so nicely mentioned, Dr. Gonsalves nicely mentioned, that you can have eosinophilic esophagitis, and that puts you at higher risk of having eosinophilic gastritis or stomach or small bowel involvement. And so your symptoms can probably, you know, sometimes overlap where you actually will have, as an adult, esophageal symptoms, but you probably also need to tell your doctor if you are having severe stomach pain or nausea or something that you don't always attribute to your esophagus. Because again, that we talked about, even when you have disease, when it's below the esophagus, you see this list of these very non-specific symptoms. And this was done in a large cohort in this registry between multiple countries where they actually said, okay, you know, what are the symptoms? And okay, maybe with the eosinophilic colitis, you might have a little bit of diarrhea and some bleeding and abdominal pain, but everything else, when you have eosinophilia involving below your esophagus, or when you're a child, even in your esophagus, you can have any of these symptoms. You can have getting full super fast, right? You eat and you suddenly can't eat anymore. Or you can have a loss of appetite. You're not hungry. You can have severe bloating when you eat and you feel uncomfortable, nausea, vomiting, and all those things could be one area of involvement. It could be that you have disease in your stomach, or it could be that you have disease now in your small bowel. So unfortunately, we don't have symptoms that are specific because a lot of other patients present with these diseases, people that have, you know, lactose or lactase deficiency, people that have, you know, functional gut disorders all present in a similar way. And so you really have to have that heightened awareness to be able to tell your physician, like, I have a family history of eosinophilia or of atopic disease, so I may be at higher risk of these other conditions. Could you please look for that? And even when they look, a lot of times what people and what, it's just in medicine, we want something to look abnormal before we feel like we need to do anything invasive. So we want like that endoscopy to look abnormal. And Nimi went over a little bit of like how some of these changes, how we see nodularity or ulcerations in the stomach in the disease. But a lot of these registries that are looking at patients that have disease, not just in the esophagus, but in like the small bowel or in the stomach, the endoscopies are described as looking fairly normal. So you have to have this high index of suspicion. And sometimes being on the patient side, you have to almost educate your caretakers about it. And that's just part of a new disease. This disease is relatively new. We're learning more about it. And sometimes you have to be a strong advocate for yourself and for your family member. So Nimi showed you already what is the natural history of EoE, and the natural history that we believe in most patients is that over time they become fibrostenotic. So they stricture, they narrow, they have problems. The natural history is not quite as well known for eosinophilic gastritis, eosinophilic enteritis, or eosinophilic colitis because they're much more rare. But what we do know based on some prior data that's been studied is that it looks like these other eosinophilic disorders actually have varying like natural history. So like some will have a continuous course, constant symptoms, constant problems, constant inflammation. Other patients will kind of flare once and never really flare again for a long time or at all. Other patients will have multiple flares. So you flare, you feel better, you flare, you feel better. And if you've ever been a patient where you've actually tried to enroll in a clinical trial in any of these, don't be sad if you didn't qualify. You might have just had a flare. You might be the relapsing remitting type, almost like other types of autoimmune diseases that we see. What Evan Dellen's group did, I think this was out of University of North Carolina, is they actually said, well, let's just look at our cohort and see if we can kind of predict how patients present. And so they looked at like, okay, if you have eosinophilic gastritis, which is the EOG on this graph here, and you have it in conjunction with enteritis, or if you are young, less than 18 versus older than 18, can we predict what's going to happen, like what your clinical course is going to be? And again, remember, this is very hard. But first, we have to identify the disease. And then once we identify the disease, we have to identify people that are going in these different courses, right? And so it's a very difficult thing to do to track natural history. But what he did find is that in patients that seem to have multi-organ and small bowel involvement, that they showed more relapsing and or kind of progressive disease, so that they were coming and going kind of out throughout the year. So never really got better and stayed better for a long period of time. And then also identified that in children, continuous disease seemed to be more common. So that children, probably with this upregulated kind of immune function, they seem to have continuous symptoms, continuous issues with inflammation. Subsequent to that, or actually not subsequent, but before that, actually, the Denver group came out and they had looked at children and they said, okay, well, what if we take our population of eosinophilic gastritis? So I'm only talking about gastritis at this point. Dr. Dellen looked at small bowel and stomach. They said, okay, we're just going to look at the patients that have disease in the stomach. What can we anticipate? And what they found is that about 25% went on to having persistent recurrent disease, and that complications sometimes could be anticipated based on how they presented at baseline. So if they presented with complications, with malnutritions, with severe endoscopic disturbances, that they were more likely to have complications over time. And these are the kind of the complications they looked at. So they found that anemia being one, like iron deficiency, not having adequate blood levels, low protein, so hypoalbuminemia, so malnutrition, if they were already hospitalized, if they already came in with a bowel perforation or surgery or a bleed, like an upper GI bleed, that these complications would then predict more complications in follow-up. So the more severe you present, the more likely you are to have severe complications later on. The one thing I think we have to remember is that EoE is chronic, and EGIDs, we think, the majority are chronic, but we aren't really sure, again, like looking at this natural history. So dealing with a chronic disease, what we need to know is that when, like Nimi so gracefully presented all of that data on how we can treat our eosinophilic esophagitis patients. But I think the take-home point has been actually also, in addition to the fact that we can get it under control, is that it doesn't mean that you can walk away and not have to be seen again. Because as this graph shows you, the longer time you come off therapy for at least eosinophilic esophagitis, the higher the likelihood your disease is going to come back. So technically, once you establish care with somebody, and once you are establishing care, if you are a healthcare professional, you really want to see them back at least once a year because the disease itself doesn't typically go away. And then even if you keep them on topical steroids, there is a recurrence rate so that as patients are manipulating, whether it deals with compliance, whether it deals with like some sort of refractory disease, there is a chance that patients can recur while they're still taking chronic therapy. So again, it argues that over time, this is a patient population, we are this patient population that needs to be seen periodically, even if we're feeling better. All right, I don't want to ignore eosinophilic colitis. It's hard to fit everything in, so I apologize, guys, if you want more information on eosinophilic colitis, and I'm sure we can talk a little bit more about it afterwards. Eosinophilic colitis is harder to diagnose, I think, for many of us. I think part of the issue is, we're already reticent to do upper endoscopies on people. It's even more reticent to do lower endoscopies on people, and people are more reticent to get a lower endoscopy. The symptoms tend to be, sometimes people have blood, they have bloody diarrhea, they have pain. It is fairly rare. It is the rarest of all the eosinophilic disorders. The natural history, therefore, is much more muddied. There is a question about whether it can come and go, whether it stays. It does seem that the younger the child is that gets diagnosed with eosinophilic colitis, the higher the likelihood it could just respond over time. Now, that may be years, but it could respond. And I have a couple patients that had colitis as a young child, and then I just follow them now, but I have not seen a recurrence at all for several years. If it does occur as a young adult, it seems like that might be more of kind of a chronic course that we have to follow our patients. So I didn't want to leave out eosinophilic colitis, but we really don't have as much data on this due to the rarity of the disease. Okay, so what I want to do last is just talk a little bit about how this is. It really does take a village, and that's basically my last slide. But there are so many, as Nimi talked about, comorbid conditions, in part related to just the burden that the disease puts on patients. So anxiety disorders, depression, adjustment disorders, post-traumatic disorders, and then feeding disorders, eating disorders that seem to correlate or come on due to these disease states. And actually, my son has an eosinophilic disorder, and it's funny to watch him now, like not funny, but like we plan our meals a little bit around what I know he will allow himself to eat and what he won't allow himself to eat. So that is normal for having a disorder where, I mean, it's very difficult to have a disorder where everything that you surround your life around, socialization, enjoyment, which is food, suddenly becomes your enemy, right? And so it's natural that this would take a toll on your psyche and take a toll and make it frustrating because you can't go out and socialize as well. When you're having to worry about having a reaction. The other thing I wanted to bring up is that we also see a lot of atopic conditions in EGIDs. So we see things like allergic rhinitis, asthma, definitely more common in EoE. We see food allergy, anaphylaxis, and then other allergies that seem to be more prevalent in a population with eosinophilic disorders. And then, oh, sorry, I'm getting got distracted. They're admitting somebody into the conversation. And then, sorry, I was trying to take care of that. Also, just be aware that a lot of the genes that predispose people to atopic disease and allergy also predispose them to autoimmunity. So there is more research going into not just in EoE, it's easier to study EoE because it's less rare, but also in lower eosinophilic disorders about concurrent conditions. So having a higher likelihood potentially of autoimmune conditions like lupus, rheumatoid, autoimmune thyroid disease, celiac disease. They have diabetes, Sjogren's, and then I think Evan-Dellen, and we have some data on some of these neuroimmune disorders like postural orthostatic tachycardia syndrome. So we do see these other relationships, and whether it's like an environmental impact with an underlying genetic predisposition, whether one begets the other is still research that will be done, and that is in the future work I will not talk about today because I don't want to take up too much of your time, but I'm happy to talk about it in the question session. So I think people are looking at that association when people have an ongoing, maybe inflammatory bowel disease like Crohn's or ulcerative colitis, and you have EoE or eosinophilic gastritis. What does that mean for the patient? And that is work that I think people are actively trying to figure out. And also, is that an area where we can start to really tailor and personalize our therapies for patients? So it's important, I think, for everybody to realize that often you may have disease in your GI tract, but you may have other concurrent diseases. And so it takes a large effort for all of your physicians and your healthcare providers to communicate so that you can get the care that you really need for your disorder. So future work, I just wanted to bring this up. This is just stuff that people are working on right now. This is a picture, it's like a heat map, and it's basically where you take biopsies and you run what's called the transcriptome. So you look to see what genes in that tissue are getting upregulated, what are downregulated, and how that differs a disease state from normal or controls. And so we've actually taken a little look at this and looked at this in eosinophilic gastritis and eosinophilic duodenitis. I'm not going to show you everything, but looking at how maybe there's different phenotypes in eosinophilic gastritis. So EoA in this picture here is eosinophilia of the antrum. So this is in like the bottom part of your stomach, not the top part. We were actually differentiating if the disease presents differently in the stomach. And so looking at that EoA, which is the pink highlighted area there, you can see that there's probably some different phenotypic presentations, meaning that eosinophilic disease is maybe not one shoe fits all on patients. And so this is going to get further delineated, not just with research being done in this way, but also research being done by clinical care, which I know that Northwestern and Dr. Gonsalves have done quite a bit of work because they have a very large population. The other thing that we're looking at is we're looking at if you have disease in a part of your body that's quote unquote not involved, meaning you get biopsied and they're like, well, you don't have disease there. What does that mean? Does that mean you're abnormal or are you normal? Are you really normal? And what we're finding, if you look at the 2U signature here, which is the pink, that's the uninvolved tissue, the tissue that otherwise would not have qualified you as having disease. And you can see that it's remarkably different than people that actually don't have disease at all. So there are maybe signals that we're going to be able to pick up to get this diagnosis earlier for people and maybe find other biomarkers that will help us identify and treat patients earlier on. The other thing that I think is being done currently is people are now saying, okay, now that we know that we can look at these signals, let's find patients that present in 2020 and get diagnosed with EOG, but actually got biopsied for the exact same symptoms in 2018 and didn't have the disease at that time. And let's see if there's a difference there. And as you can see here, there are markers that are differentiating this pre-disease from controls, people who never developed eosinophilic disease. So this is all this future work. Maybe we're going to be able to find biomarkers that will predict the onset of disease. So this is all work that's being done and will hopefully give us much more hope in the future that we can identify things, and hopefully not even in tissues, but in blood work. And then finally, just really quickly, the Cincinnati group and Seeger looked at peripheral markers, ways at that biopsies and peripheral markers. And you can see the heat map up here on this slide as well, finding that there are definitely markers in the tissues that differentiate disease in the stomach from people who don't have disease. But they also said, oh, well, maybe there's some blood markers too, so we're not having to do endoscopies all the time. That needs to be teased out a little bit more because as we talked about, those blood markers could be influenced by all of those comorbid diseases I told you about, like allergy, autoimmunity. But again, it brings up a possibility that maybe we can identify things even on a blood draw that would put people at increased risk. And then I'm just going to end with this really quickly. This is a a study that's being done by Ashley Pine. So she is a PhD in nutrition, and she is a registered dietitian who specializes in eosinophilic diseases. And she and actually Dr. Gonsalves on this call today actually put in a grant to follow up on some of the work. So she said, okay, well, we're down there doing an endoscopy. We always have to take out the fluid so we can see the tissue. We're always aspirating the fluid out. Are there markers just in that fluid that we're aspirating out and throwing away? So she took that fluid and she said, okay, I'm going to look at eosinophilic gastritis patients. I'm going to look at people that were biopsying because they have abdominal pain and see if there's something that could tell me that that's an eosinophilic gastritis patient so that I can go tell the pathologist, I really need you to look at this tissue so I can get this patient diagnosed. So she took a series of about 20 EOG patients. She took EoE patients that didn't have EOG just so she could control for any contamination in the stomach. And then she took these kind of control, just abdominal pain patients. And she looked at markers. And what she found is yes, you can find markers that differentiate these patients, and they can differentiate them from EoE patients, and they can differentiate eosinophilic gastritis from control patients. So we're moving closer to being able to identify patients earlier on and hopefully take care of that delayed diagnosis because we don't know when to tell our pathologist to look more closely at the tissue. And she and Dr. Gonsalves have a grant application going in together to work together on this. So I'm just kind of highlighting their work here. Okay, so that's my long spiel. Sorry, and it was kind of fast. I do talk really fast, so I apologize. I think the take-home point is that we all need to recognize that EGIDS, it takes a village. It takes a village to take care of this disorder because you need your primary cares. You need primary cares in part because of all the comorbid issues that go along with EGIDS, that we get on top of it, that we can treat the anxiety, that we can treat the feeding disorders. You need allergists because of the atopic conditions. You need, and allergists, honestly, in the United States, allergists are great because often many allergists are trained both in pediatrics and adults, and gastroenterologists are not. And so having that transition of care occur through an allergist is much more smooth, although we probably should study that to really prove that. That's just my opinion. You need your gastroenterologist. You need ED doctors. If you show up to the ED doctor needs to know that you are at risk for this disorder and to know how to schedule a follow-up, not just do a CAT scan, not just do an ultrasound, to schedule a meeting with a gastroenterologist or an allergist. And then these specialists, right? You have atopic dermatitis and you have nausea, vomiting, abdominal pain, or choking. We need dermatologists to be able to have that communication with a gastroenterologist or with an allergist to make sure that you are well taken care of and everybody talks back and forth. If you want dupilumab for your asthma, but you can get it weekly for your EoE, like that conversation needs to happen, right? So we need that in suspicion, we need that in detection, and we need that in management. And in addition with management, we need psychology, we need dietitians. It is not a disease to be taken lightly at all. It is a disease that has multiple ramifications, and we need a village to help take care of everybody. And with that, I just wanted to thank you for your time.